Okay, so good afternoon, everyone, and welcome to this OCI Special Interest Group Binocular Vision webinar, which is on Introduction to Neuro-Optometry. Wish you all a very happy Makar Sankranti. So, as you all know, OCI has five special interest groups on the Facebook. They are in dispensing optics, low vision care, binocular vision, clinical optometry, and public health optometry. So these groups are free to join. You can join them, and we usually conduct monthly webinars for each of the groups. So today the session is on introduction to neuro-optometry. So as our understanding of the vision continues to evolve, it is increasingly clear that seeing is not just an optical process, but a complex interaction between the eyes and the brain. So neuro-optometry helps us to understand how visual input is processed, integrated, and translated into perception, movement, and behavior. Making it highly relevant to the binocular vision, visual comfort, and functional performance. So today's session will introduce key concepts in neuro-optometry and highlight their clinical relevance for the optometrist. And we hope this webinar sparks some curiosity, strengthens your clinical insights, and encourages further exploration into this exciting and emerging area of optometry. So to give this talk, I would like to welcome Ms. Bidisha Bhattacharya. She is currently working as an assistant professor at NSHM Knowledge Campus, Durgapur. She is highly skilled optometrist with a bachelor's degree from Vidyasagar College of Optometry and Vision Science and master's degree from GD Goenka University, Gurgaon. With over 6 years of clinical experience in binocular vision and neuro-optometry, Ms. Bidisha worked in renowned hospitals like Shankar Nethralaya at Chennai and LV Prasad Eye Institute at both Vishakhapatnam and Hyderabad campuses. Later, she found interest in academics and she is now continuing her career in serving as professor. Her research contributions include 5 publications in reputable national and international journals, highlighting her expertise in the field. So, welcome, Ms. Bidisha Bhattacharya, and thank you for accepting our invitation. Over to you now. Yes.
Thank you so much, ma'am, for the kind introduction. I started to share my screen. Is it visible?
Yes.
Good afternoon to everyone. I would like to invite each and everyone and very much thankful for me to invite over here. The topic of discussion for today is very, very interesting, and this is the first session, I hope, and we are going to discuss about the introduction of neuro-optometry. So first we have to discuss about what exactly neuro-optometry. Obviously, it is a part of optometry, but there is a speciality, I would say. So it is a specialty field of vision care that combines neurology and optometry that will help to evaluate functional vision problems arising from neurological conditions and traumatic brain injury. And basically, when the communication is having some disruption between the brain and the eye, the patient started to have some dysfunctions due to injury or any kind of diseases, and that's why different types of vision problem like asthmatic symptoms, diplopia, blurring of vision, field vision loss, these are the things patient usually started to have due to this failure. So the next is that most important part of our discussion, that the role of a neuro-optometrist. So basically, a neuro-optometrist, specially trained in diagnosing and addressing visual problems associated with neurological disorders, plays a vital role that, and they evaluate and manage conditions such as binocular vision dysfunctions, visual processing disorders, and visual deficit following the brain injuries. And after that, diagnosing is not the last part. After diagnosing, it's very much important that we have to rehabilitate those patients. So that involves addressing refractive error with spectacle or contact lens, employing tinted glasses to reduce photosensitivity and discomfort, and utilizing the occlusion to manage immediate or awkward double vision and the postural such symptoms. Apart from that, vision therapy that will be the combination of accommodative and vergence issue along with the hand-eye coordination are highly recommended to address sensory motor and visual processing integration deficits. So after that, the neuro-optometrists are basically dealing with acquired brain injury patients. So acquired brain injury, that means ABI is an umbrella term emphasizing that these conditions that appear suddenly and result in a neurological dysfunctions. After that, ABI is highly classified into two main categories. The first category is traumatic brain injury, and the second one is non-traumatic brain injury. So, first we are going to talk about traumatic brain injury. But prior to that, apart from the clinical definition, there is another one definition is also highlighted over here, which was given by World Health Organization, who acquired brain injury refers to damage to the brain occurring after birth and unrelated to congenital or degenerative diseases. And these impairments may lead to temporary or permanent consequences, causing partial or functional disability or psychosocial maladjustment. So now we are going to briefly discuss about traumatic brain injury. So the first term is traumatic brain injury and the results from an external insult of the brain. The particular physical event can be classified as closed or penetrating head injury. Okay, so now we are going to talk about these two main another sub-classification of traumatic brain injury. The first one is open head injury or penetrating, another one is closed head injury. Okay, so after that, the non-traumatic brain injury. That means there is no penetrating injury, there is no other external affair. Due to having the malfunctioning inside the brain like hypoxic condition, any brain meninges, tuberculosis, cerebrovascular accident or brain stroke, or any other due to ischemic condition or metabolic disorder, patient may have some internal bleeding or blockage that will be classified, but that will be identified through the MRI or CT scan. So non-traumatic brain injury is quite different as compared to the closed head injury. So the next part is that under the traumatic brain injury, these are the two main classifications, that is closed head injury and penetrating injury. So in closed head injury, there is a two type, that is Coop injury, and next one is the control Coop injury. So what exactly it means? Acceleration or Coop injury occurs when an object in motion such as gun or fist strikes the head, or when a head in motion strikes a stationary hard object. This can result in skull fracture, subdural or epidural hematomas, and contusion of the underlying brain issue. Next is that contracoup injury or dislocation. This occurs after the head is in motion and strikes a stationary object. In automobile accidents, both type of injuries can occur. Next is that penetrating injury. That means in penetrating head injuries result primarily from gunshots or sharp instruments, and that damages the axonal point. Conditions that constitute the second group under ABI result from the internally based brain insults. So these are the two main classification which comes under traumatic brain injury. Next, after if a patient is suffering from traumatic brain injury, what are the issues they are going to face in their day-to-day life? So, before reaching at the proper diagnosis, we have to follow such a pathway. And the pathway basically started from the cause. So, and that will obviously comes with the proper history tracking. So, the causes will be addressed in a proper way is the very primary and crucial thing. After that, which type of injury should be administered? Neuro-optometrist's role will come when a patient will be referred to the neuro-optometry through a neuro-ophthalmologist. Immediately after road traffic accident or any cerebrovascular accident, directly those patients won't be referred to a neuro-optometry clinic. First, they will be getting medicine, and if they are injured they will be getting trained at the hospital. After that, when they are having some issues related to their brain, they will be sending to the neuro-ophthalmologist. After their MRI or CT scan evaluation, when they found that they are having some hand-eye coordination and binocular vision related issue, any field loss, for that rehabilitation purpose and proper evaluation, those patients will be referred to us. So, first part is to understand the cause, then which type of injury, next what are the effects are there. That means if they are having closed head injury, that means either that can be coup or contra coup. So what are the issues? Is there any problem in their verbal communication, motor activities, eye opening? If there is a blunt trauma, then what are the other issues they are feeling in day-to-day life? So these are the effects are very much important for us, like neuro-optometrists should know. Then, due to having this accident, what are the issues they are facing? If they lost their one eye, if it is traumatic optic neuropathy, they will be blind for one eye. So, what are the impairments were done in which part of the eye or body? Everything should be administered in your history taking. The last and most important part is there, that is impact. There are the two conditions where the patient will definitely have some impacts. One is neuropsychological and oculomotor. When they started to have some deficiency, they will start to lose their eye contact. They will feel underconfident. So, neuropsychological and oculomotor deficiencies are found to be the most common immediately after accidents. So, what exactly that means? These neuropsychological consequences means patients may experience various cognitive deficits due to diffuse axonal injury. These deficits include slow information processing and impaired long-term memory, attention, working memory, executive function, social cognition, and self-awareness, any working related memory, executive function. Mental fatigue is also frequently associated and can exacerbate the consequences of neuropsychological deficits. Apart from that, the survivors of the severe traumatic brain injury frequently show drastic personality changes and behavioral issues, which can have major consequences on family, social, and vocational integration and any quality of life. The next one is that very important oculomotor dysfunction. So that means injury to vision related areas of the brain can also result in a range of dysfunctions, including oculomotor, color vision, contrast sensitivity, visual field related issues. This oculomotor system broadly includes the versional, vergence, accommodative systems. Resultant symptoms of disturbed oculomotor symptoms are diverse and may include diplopia, blur, difficulty following targets, oculomotor-based reading problems, and asthenopic symptoms, while producing vision discomfort and possible loss of visual efficiency. Oculomotor problems may negatively affect the overall rehabilitative process and thus impacting adversely on an individual quality of life. So here comes that if you are going to deal those type of patients, what are the pathway that you have to follow. These will be the following steps that has to be taken when you are dealing a patient in the separate neuro-optometry workup. So first, this patient will get registered for the comprehensive eye examination clinic. Maybe it will be neuro-ophthalmology clinic. There also they will take the history taking, they will do the comprehensive eye examination, color vision checking, contrast and retina evaluation, and any other investigations. But after having those investigations, when they are found to have some neuropsychological issues or any other oculomotor dysfunction or field defect related issue, those will be referred to the neuro-optometric workup. So another 10 minutes, what I am going to discuss, this is separately a proper format for neuro-optometric workup. The first thing that everyone should follow, that is history taking, because we believe that a proper history taking will give us a rise to a proper diagnosis. So what are the basic points needs to be covered when you are dealing a patient with a neuro-optometry? So first thing is that demographic details are very, very important. I hope everyone is aware of that, that what are the questions needs to be asked, like age, name, date, from where exactly they are belonging. Most important part is that if patient is not enough stage to talk to you properly, if they are very much underconfident or they are just misdirected, so whoever will come with them as a attender, so we have to ask those questions to them. Next is that chief complaints. What are the issues they are getting immediately after the accident that has to be written? Maybe there is a possibility due to having some neurological dysfunction, they will start to talk more and more, but you have to be very much patient when you are dealing with those patients, and you have to capture what is the actual complaint they are having. If it is eye related issue, if it is a double vision related issue, or if patient is a Parkinson patient, so what are the motor, other visual motor dysfunction they are having, the vestibular issues. So everything needs to be administered when you are asking about their complaints. Next is that ocular history. There is a highly possibility that they have gone somewhere else and they were treated something. So recent ophthalmic consultations also needs to be written inside your report for further progress and further information. Next, previous investigations report. Maybe there is a possibility they have gone somewhere in a hospital and they don't have this kind of neuro-optometric facility. So they had done the Humphrey visual field as per the neuro-ophthalmologist, and these ophthalmologists referred to your clinic for further evaluation and treatment. So if they had done HVF, OCT or any other diagnostics, you have to mention the recent report in a medical records. Another one thing that has to be mentioned, if they have come to your clinic after the accidents, maybe I think within 15 days or 10 days, so MLC should be written under the guidance of your ophthalmologist. Next is that this is very, very important, and this is highly appreciated when you are asking about the neuro-optometric workup. This is a separate part which is not currently used in our comprehensive eye clinic or neuro-ophthalmological clinic. This is judgment of severity of acquired brain injury. And this only is available in our worksheet of neuro-optometry workup. So what exactly this is? So how we are going to judge this acquired brain injury, whether it is mild, moderate or severe? So basically it is having three perspectives. The first perspective is Glasgow Coma Scale, that is known as GCA scale. Basically it is a neurological scale and purely it is objective, and basically it gives the conscious state of the person after head injury, and it is highly reliable. So basically we are going to ask few questions based on the three components and how much is the score, and based on that score we are going to finalize that which type of GCS patient has. So this is the table and we are following in our day-to-day life. These are the three components: eye condition, verbal communication and motor activity. So these are the three components, and we have to ask those questions to that patient if he or she is in state to reply you immediately or accurately. Otherwise, attender you can ask and they will reply to you accordingly. So yeah, I would like to request everyone to go through this, the number sequence. If you see the least number as showing a more severity, and when you are reaching to the higher orders, that is showing that there is a mild improvement or the patient is in conscious state to move their bodies after the road traffic accident. So based on those questions and understanding, we have done an analyzation, and we have found that if total score is less than 8 or 8, the severity of the condition is more. Next, and severe, that is total score 13 to 15 and moderate 9 to 12. Next is that post-traumatic amnesia. The first part is that the condition after that accident, and next one is that what is the condition of their memory. So this is known as post-traumatic amnesia. So in traumatic brain injury, patients usually experience a blow to the head of sufficient magnitude to result in either a loss of consciousness or post-traumatic amnesia. So what exactly it is that PTA? Post-traumatic amnesia is a state of confusion that occurs immediately following traumatic brain injury in which the injured person is disoriented and unable to remember events that occur post-injury. And we have found there is a two types of post-traumatic brain injury. The first is that retrograde amnesia and anterograde amnesia. So let's discuss about that. The first part, retrograde amnesia, denotes this is an inability to access memories or information from before an injury or disease occur. So whatever was happened prior to that accident, they are totally forget about it. So they don't remember, but still they can, what if they can remember what exactly happened after the accident. So this is quite common. If you see those patients are come to your clinic, they will be suffering mostly from retrograde and amnesia. What is the other type of amnesia? This is anterograde amnesia. This is nothing but they are having some inability to make new memories. So how it is? This is basically an inability to create new memories after an event that caused amnesia, leading to a partial or complete inability to recall the recent past, while long-term memories from before the event remain intact. And based on these questions, again we have done some analyzation that will give an assessment the condition severity. If it is severe, that means patients forget about their memory for more than 7 days. Moderate condition if it is within 1 day to 1 week. Mild if they forget about only less than 1 day. So this is a criteria with which you can analyze those patients in their severe conditions. The last and another one most important criteria for getting the severity of acquired brain injury is loss of consciousness. So unconsciousness is a state in which an individual loses awareness of themselves and their environment. It may occur as the result of traumatic brain injury, brain hypoxia. And if the duration of loss of consciousness is greater than 20 minutes, and that is quite severe. If it is less than 30 minutes or within 21 day or 24 hours, it can be called as moderate. But if it is less than 1 day, like 24 hours, it is mild loss of consciousness. But approximately 15% of traumatic brain injury patients are considered moderate to severe, with most individuals left with significant changes in physical, cognitive, and affective functioning. So, based on these three criteria, or you can say that qualitative assessment, we can note down the actual condition of their brain injury. So based on the three category, we can note down the severity of their brain injury. After finishing this type of history taking, we will be further moving towards the previous treatment. A few minutes back, when I was telling that there will be a such patient that will be coming to your clinic as a second opinion or third opinion, or they might have gone somewhere, they have done some exercises or visual motor activities with Sanit Vision Integrator, Revital Vision. So if they have gone through such occupational therapy, speech therapy, neurological care, physiotherapy, and psychology counseling, everything needs to be mentioned over there, because as we are dealing such a patient which is not normal in conditions, so the duration, the starting date, the end date, the sessions details, everything needs to be mentioned in our medical record. General health, if they are suffering from any other systemic diseases, the duration, the medicine name, the units, everything needs to be written. Apart from that, the most important part, if they have brought some MRI or CT scan report, that will reflect their blockage or leakage, or maybe you can think about the visual cortex lesion. That means bitemporal hemianopia or binasal hemianopia. So those patients, if they have brought some Humphrey visual field report and MRI reports, the interpretation for those reports needs to be written properly. That will also enhance our knowledge that which way we have to go through and what are the treatments we can think about. Next is that as a rule of comprehensive eye clinic, we have to again perform the vision assessment along with the refraction. And refraction includes both objective and subjective method. Here, I would like to highlight one or two points. That is, if they are having some vestibular issues, visual motor integration related issue, any kind of processing disorder like visual audio, so vestibular ocular reflex needs to be checked along with the normal visual testing. So after this refraction and refraction, now we have to start like full orthoptics evaluation. So basically this is the starting of our presentation, and today we are going to do only the introduction to neuro-optometry. So probably in the next section we are going to start that what are the tests or evaluation should be done in specific cases, where we are going to discuss about the different cases along with the rehabilitation process for individual case. So now at least I am going to highlight that what are the specific tests needs to be done when a patient comes to your clinic with this type of issues. The very first thing, sensory evaluation needs to be taken. If the patient is enough capable to understand the stereopsis evaluation, go ahead with it with RAN dot either or TITMAS and Watford dot test, both for distance and near with the proper correction. Next is that in the motor evaluation, there is a two-way. First is that the eye movement needs to be checked and ocular motility. So eye movement basically includes saccades and parts weight. There are multiple tests. I hope everyone is aware of it. And I would request if any students are there, please write down at least 2 or 3 tests which you know that have to be performed to check the saccades and parts weight. Anything, manual exercises, manual test, or any digital, anything is okay. So after checking the saccades and parts weight, then we will be starting with our ocular motility with the broad H test, and followed by if they are having some traumatic fourth nerve palsy or third nerve palsy, under action of muscle in particular which case have to be drawn also in the medical record, or you can mention in the ninth ordinal case that where. After that, objective evaluation or subjective evaluation of squint needs to be done. That can be done with a cover test, or if we have muscle imbalance method card, both for distance and near. After that, if patient is quite cooperative with you, then you can do some NPC, NPA with RF ruler. With accommodative test target, I would request. Otherwise, the patient would be don't having much patience to understand your non-accommodative target with red and green. If after that patient can read something or can fixate the target for a longer period of time, then go ahead with Burgess facility and Burgess amplitude. Otherwise, first you just try to check their saccades parts weight, at least the covert test or the near point of convergence. Then do some exercises. After the post exercise, then you can check the further things that will enhance their circus parts weight also. And next is that why I want to highlight the point K, that eye movement test, because saccades and parts weight are the first primary thing that can be having some issues due to having the injuries. Basically, like more adults are having acquired brain injury as compared to children. But in my career, I have seen 2 cases. 8 years old, while she was going to her school, suddenly she had an accident with a truck when she was riding a bicycle. And followed by she had left homonymous hemianopia along with severe reading disability like dyspraxia. So for those patients, if we are going to check NABPF, it won't be possible for them. So if you remember when I was discussing about the pathways of treating a patient, the first one was the cause. So here also it will be applied. I would say that based on the condition of the patient, judge about the evaluation tests. Then you, after you just give some exercises that will enhance their mobility, then we can think about further tests like vergence and accommodation. But in the other cases, like if they're having Parkinson diseases, those patients will be having motor dysfunction along with the vergence dysfunction. Those patients, we have to do the other evaluation tests. So in the next session, when we will be discussing about the different cases, their evaluation process and the rehabilitation, the idea will be more clear to all. Coming back to the eye movement test like saccades and parts weight, I hope it is quite familiar to everyone. N is UCO scoring to check their saccades and parts weight. Basically, their hand and body, head and body movement, accuracy and ability. It is quite same as GCA scale that there is a numbering system. If it is 0, that means patient is having severe movement while you are checking the saccades. So basically in our normal clinic, using 2 colorful pencils, we are checking the saccades. If we don't have the other King David test, DEM, Riedelizer, any other exercise. So instead of this, we using these 2 pencil, horizontal and vertical saccades can be checked. If you have vision therapy system 4 installed at your clinic, that will be well and good. This is a process where you can diagnose also and you can treat also. So based on the NACO CO scoring also, you can able to write that the condition of OMD. If there is a hand-eye coordination related issues along with Sakars and Parswick, this is known as ocular motility dysfunction patient. Here is also the severity can be there. Based on the development eye movement test, we can judge the condition of OMD. After doing this many evaluation tests, finally we have to write each and every diagnosis. Like when you have done the refraction, you may find about simple myopia in both eyes. So your answer, like diagnosis, should be started with simple myopia both eyes. Next, maybe it can be OMD or any convergence insufficiency or any left homonymous or right homonymous hemianopia, anything. So if it is a field defect issue, then confrontation should be done for that patient. And HPF, if they had done and came to you, well and good. If they didn't go for investigation first, but directly came to you, your clinic with the referral of neuro-ophthalmologist, then before starting the evaluation, that will be our responsibility to check their dilatation and everything and send them for the further investigation and come back to you. After the diagnosis, then we may think about the strategies of management. If each and every individual will be preferred for the different exercises. In the very beginning, when I was talking about the neuro-optometry rehabilitation, I have talking about that combination of verges and accommodation. So if they are having some brain dysfunction, that will be affecting mostly like two conditions, vergence and accommodation. So we have to strategize a proper sessions. It can be 10 sessions, 20 sessions. In each and every hospital, the criteria may be different, but if you follow Dr. Zamil Rizwana's PhD in the year of 2017, which was done in Chennai, in the southern area of India, along with Shriman, they have found that the most effective strategy will be either 10 sessions of in-office vision therapy, 1 hour per session in every day. Otherwise, if patient is not enough capable to come to your clinic daily, at least home vision therapy for 3 months. My best strategy is that first few sessions you have to observe that how patient is dealing with it. If we are talking about the response through vision therapy, then we can think about some feedback mechanism. Again, I would request if anyone is interested, kindly write down at least 2 or 3 feedback mechanism, which is very much common when a patient is doing some vision therapy at your clinic. The clue can be suppression, blur, diplopia kind of. So better, it would be better that those patients after evaluation, you first observe for few days that how they're responding. Based on that, maybe you can think about such a combination of some manual exercises and digital exercises at home. So through this, maybe I can take a short release. So after this conversation, I am open to all. Whatever the doubts they are having when dealing a patient with the neuro-optometry workup basically. Hence, we didn't complete the rehabilitation full process. So I am open to everyone. Whatever the doubts or difficulties they are facing with dealing those patients, they can ask me.
Yes, thank you. Thank you so much, Vidisha, for this insightful talk. If participants have any questions, they can put them in the chat box. Any questions from the participants? Okay, Bidisha, meanwhile, I would like to ask you one question. How can neuro-optometry principles they can be applied in patients with those who have a persistent symptoms despite all the normal clinical findings?
Persistent symptoms like, ma'am, can you just elaborate once? What are the other symptoms you want to address?
Maybe a headache or something like that, which are you won't be finding anything in the clinical findings. Everything is normal, but still they are having symptoms like this.
Yes, ma'am. This is a very good question. I would say that most of the patients, because from the neuro-ophthalmology clinic, few patients they are misdiagnosed to have neuro-optometric issues. There
Right.
is a two, three conditions. If they are having some previous history like any cerebrovascular accident or any non-traumatic issues, and any kind of road traffic accident after having some dysfunctions in the brain due to having some neurological disease or dysfunction or injury, those patients should be called as neuro-optometric issues. But other patients who are working as a IT professionals or teacher, they are having some headache issue after prolonged near work, they are not the neuro-optometric. They can refer to the orthoptics clinic. Basically, wherever I got trained and I walked over there, there is a two station. One is orthoptics clinic, another one is a neuro-optometry clinic. Most patient which having the previous history of injury, accident and brain related dysfunctions, those will be dealing with the neuro-optometry because our worksheet is totally different as compared to orthoptics clinic. In orthoptics clinic, we are taking the history related their working, what are the issues they are facing, and we are doing our sensory evaluation and motor evaluation. We didn't ask about their any other dysfunctions like perceptual disorder and everything. And
Oh,
but typically in neuro-optometric patient, if they are having some convergence issue, that will again due to affected due to the brain dysfunction. So Saccard's persuade the reading disability, which are mostly common in neuro-optometry, as compared to the patient which doesn't have any further issue, only convergence and accommodation issue.
okay. Thank you for that. We have few questions in the chat box. Okay, how neuro-optometry is different than the forensic optometry?
Yeah, this is very much different because forensic optometry is totally different. Because in our neuro-optometry, we are dealing that patient which can come to your clinic with a proper adventure. So this is not our part of discussion that forensic optometry. These are very different logic and the sciences are totally different. So basically, if they are having some binocular dysfunction or oculomotor dysfunction, those issues can be treated in optometry, but forensic is totally different.
Okay. Um, okay, the next question is okay, Mr. Nikhil is saying, hi, nice presentation. Do you think of checking vision midline shift in TBI cases? And if
Very,
what
yes,
do
yes.
you recommend? Yeah.
Yes, thank you, Nikhil, for give me a reminder about it. Once I didn't speak about the visual midline shift syndrome. Seriously, yes. After having these severe field losses, they starting to move but tilt their head towards that affected zone. So vision check with the proper visual motor or oculomotor reflex should be checked if a patient is having some traumatic brain injury with visual shift syndrome. So this is a very good question. And I hope maybe in the next session, when we are having a topic on post-traumatic vision syndrome patient, there I am going to discuss about the various prisms option that will help those type of patients.
Yes. Thank you. Okay, Ms. Bidisha, what resources or training would you recommend for the optometrists who are interested in, developing expertise in this area?
Yes. If there is a two criteria, ma'am. If they are having a vast interest in understanding the neuro-optometry theoretical aspects, then I would suggest over here about the two books that vestibular accomplishment. I will write in the chat box or maybe I will share in the Facebook page as well the links. As it is not available at the PDF, I only have the hard copies. These are the two main books that I follow for the theoretical aspects. And coming for the rehabilitation process, obviously clinical management of Shimon and Wick is highly appreciated.
Okay, that's great. Any more questions from the participants? Okay, Miss Priyanka is asking which diagnostic tools are essential for assessing visual processing deficits in neurooptometry.
Yeah, basically different. There are different diagnostics tools are essential in visual processing deficits. First, we have to know about the PTS, perceptual training system. One diagnostics tool is obviously available in market as well. Through that diagnostic tool, there are multiple things: visual processing, oculomotor reflex, visual enclosure, visual memory. So there are multiple options will be available in PTVS. Not only PTS, in the vision therapy system, 4 is also available, and Revital Vision, Binocs. These are, and mostly this is very new to our world, that is Neurosync. This is also a diagnostics tool is highly recommended to check with the help of VR, that the visual processing. And few patients are there, maybe they are suffering from some amblyopia, and basically if they are having some perceptual disorder also, those diagnostics tool will be highly recommended for them to treat this. First we have to diagnose their severity condition, and based on the diagnosis then maybe we can think about for further treatment. And if you are interested, Harshita ma'am, please let me know. I will share those links. From there, they will get the actual, because visual processing deficits is one part. There are multiple processing disorders like audio, visual, and for that we have to work with the vocational trainers also. So there is a possibility that when we are dealing a patient might not have only the eye issues, the other perceptual, the motor cognitive disorders patients will also be referred to our clinic. So along with the occupational therapist, as a neuro-optometry rehabilitation can also work together. So if they have interest, please let me know. I will share those links with them.
Sure, sure. Yes, definitely. We can send them along with the recording of this session. And anyways, we'll be conducting in February the post-traumatic vision syndrome and its management session for us. So maybe that
Yes.
time so we can do that. Yes,
So if there will be a time, then maybe I can show that demonstration also how exactly it works.
that would be great. Yeah, great. Okay. Last few minutes, any other questions from the participants? Okay, Ms. Priyanka is interested. And one more, how do we integrate neuro-optometric assessments into routine eye examinations?
Yeah, this is a very typical question, I would say, because for individual it will take 1.5 hours for neuro-optometric
Yeah.
workup. So if you are totally interested in neuro-optometry, so immediately after internship, you can go ahead with the fellowship in neuro-optometry either, or you can work with a pediatric ophthalmologist for another setting. But this is a good question that you have asked, how we can integrate. So few tests that can be incorporated in your routine examination. Why not? The SACARS training, you can check the saccades also, or maybe if you have some time then you can check their reading speed as well. You can, if you don't have the readalizer, you can have some reading elements with you, and 200 words per minute is a normal accepted. So these are the few things that you can do. If you are getting a patient with field loss, do the confrontation. If you having some trial lenses like ground prisms, teleprism and sectoral prism, I hope it won't be possible for you to give a training in your daily routine. This is not possible. But if you want to improve your change and you want to help your patients, then maybe ground prisms, the sectoral prism is not possible, but at least you can have some ground prism or yoke prism trial set with you that will enhance their mobility.
Yes. Okay. Okay, we have one comment from the Miss Subrato. Hi Bidisha, it's nice to hear from you. Any insights for infants with the birth complication or CVI in this topic?
Dear, first you have to understand this is a CVI,
Hmm.
cortical visual impairment, and now we am talking about the neuro-optometry. Our visual cortex doesn't have any kind of issues over here. So their assessment and my assessment, maybe the vision related deficits, the assessment will be quite similar. but we are only dealing with the processing disorder children or adults in our neuro-optometry. So this will be totally different as compared to the neuro-optometry dear. So for CVI, we can conduct another one separate session where we'll be dealing with, maybe discussing with the different assessment, because dyslexia patient, CVI patient, and the other visual perceptual disorder patient or only behavioral optometry that can be done in a separate session, because their diagnostic process, their understanding, their management is quite different as compared to a patient with a neurooptometry.
Right. Thank you so much.
But one thing, Harshita, what I will just think, what he was asking, there is a chance, or maybe I can think about a possibility. A
Mm,
child with a CVI can also have a road traffic accident, any kind of stroke.
mm.
Then there are possibility that treating or the evaluation process will be combined. Same, we will be doing some CBI assessment also as well as the neurooptometry. So then that will be a combination of assessment, diagnosis purposes, and as well as the treatment.
Okay, great. Okay, so I think that's it from the participants. Yes, so as we have come to an end of the session, I would really like to, sincerely thank our speaker, Ms. Bidisha Bhattacharya, for sharing valuable insights and, helping us to understand the relevance of neurooptometry in everyday clinical practice. This session has highlighted how a deeper understanding of the brain-vision connection can, enhance our approach to binocular vision assessment and patient management. So thank you all, and thank you so much, all the participants, for your active participation. And we hope today's discussion encourages you to explore, neuroscience concepts further and apply them meaningfully in your clinical work. So thank you so much. We'll see you next month with the continuing topic to this for today's session, which is on post-traumatic vision syndrome and its management. So Ms. Bidisha will be taking the that session in February. We'll let you know the date soon. So thank you all. Thank you all for joining today's session. Thank you, Ms. Bidisha.
Thank you so much, ma'am, for this kind
Thank
invitation.